Welcome to Let's Talk Care, a podcast about research and quality of life in long-term care homes in Canada. I'm Marco Redden, joined by my co-hosts Mary Jean Hande and Emily Hubley. Each episode, we'll look at a different piece of the long-term care puzzle and share fresh perspectives as early career researchers navigating the field.
All right. Welcome to our second episode where we'll cover the topic of quality of life in the context of long-term care in Canada. Today, we're here with Katie Aubrecht, Deanne Taylor, and Matthias Hoben, who each lead different aspects of the SALTY project. And we're the initial three members of the SALTY Trainee Network.
Yeah, so now that we have all three here, it would be great if each of you would like to introduce yourself, maybe talk a bit about your current role on the SALTY project, as well as your experience as one of the original three members of the Trainee Network. So maybe Katie, if you'd like to start off.
Hello, I'm Katie Aubrecht. I am an assistant professor in the Department of Sociology at St. Francis Xavier University in Antigonish, Nova Scotia. I'm a co-lead on the Mapping Care Relationships team that's part of the SALTY project. So I work closely with Dr. Tamara Daly from York University and Dr. Ivy Brugeau from University of Ottawa. In our work, we are focusing on promising approaches to late life long-term residential care. We use ethnographic research methods and a case study methodology. We've visited 8 different homes across Canada, 2 in each of 4 provinces. And these would be homes that are exemplars that kind of embody promising approaches to care as identified using different methods. I was a trainee co-lead on the stream, and I've recently moved out of the Trainee Network, but I'm feel very grateful for the opportunity to work with Deanne and Matthias, getting the Trainee Network off the ground for the SALTY project, and I'm really excited about the directions that it's taken under Mary Jean's excellent leadership.
Great, thank you so much. Matthias, do you want to introduce yourself now?
Yes, absolutely. My name is Matthias Hoben. Hello, everybody. I joined the SALTY team when I still was a postdoc with Dr. Carol Estabrooks, who is the co-principal investigator of SALTY overall and the lead of the monitoring burdensome symptoms and care practices team. And I have been co-leading that team with her. Right now, I am an assistant professor at the Faculty of Nursing with the University of Alberta. I am an Alzheimer's Society of Canada new investigator. And ever since, or throughout my career, basically, I have focused on frail older adults and their care and quality of life. So when I started my postdoc with Dr. Estabrooks in 2014, we started to work on some end-of-life related issues already that eventually fed into that work that we're right now doing within SALTY. So we were basically focusing on administrative data that's available from nursing home residents across Canada and how the data that is collected routinely can be utilized more efficiently or more specifically to monitor burdensome symptoms and potentially inappropriate practices at the end of life. And one important goal of the work team that we are with is to develop visualizations and ways to practically use the administrative data on burdensome symptoms and end-of-life care practices to feed that back to care teams so they can improve their practices. So that's basically the work we've been doing. We've also done work on setting priorities with stakeholders, such as decision makers and people in need of care, as well as their caregivers, like which symptoms and practices are most important to them. And that all feeds into our work, basically. So yes, it was a great experience working with the other trainees on SALTY and with the big and diverse research team. And I think we get to talk about that much more during that podcast. So let me know if you want to know anything else for now.
Great, thank you. And last but not least, Dee, would you like to introduce yourself?
Yes, thank you. So I'm Dee, or Deanne Taylor. I'm currently the Corporate Director of Research for Interior Health out in British Columbia. I also hold a Scientific Director role with the Rural Coordination Centre of BC. My role on SALTY is to, along with Janice Keefe, Dr. Janice Keefe and Heather Cook, who's a decision maker with lots of experience in long-term care. We lead the policy stream, and the policy stream in SALTY is really around examining the policy context in long-term care, but from a quality of life lens. And we focused on 4 provinces in Canada, so Alberta, BC, Ontario, and Nova Scotia. So that has been an interesting role, because it out of the 4 streams, stream 4 really was also meant to cross over and integrate with the other 3 streams. So I can maybe talk about that a little bit if you're curious later in the podcast. And like Matthias and Katie, I was one of the first trainees, and also was involved in the very first meeting that Carol Esterbrecht led when SALTY was just being thought up and created for the actual proposal. So that was quite exciting to see such a diverse group of investigators, very high-level investigators coming together, as well as decision makers, high-level decision makers. So even from the very beginning, there was an integration between the researchers and people within the system, and not shortly thereafter, there also became integration with people with lived experience. So happy to talk about that as well, but very excited to be here.
Well, thank you so much, everyone, for those fantastic introductions. And I think it's really exciting, sort of as newer trainees, to have the opportunity to have this discussion with folks who have been so involved for such a time now. So today we're talking about quality of life. And when I think of that term, I kind of think that it's a term that resonates with a lot of people, sort of as something that we understand that we all need, but we might not have a clear definition of what that looks like in the context of long-term care, or how it could be measured, or sort of how it can be improved. And I think it would be great from each of your perspectives to talk about how that's shown up in your research, how you define it, and how you measure it. So whoever wants to tackle that question first can go ahead.
Perhaps I can start. So this is Katie. Thank you so much, Marco. So with Stream 2, our focus again is on promising approaches in late life long-term care. And really we focus on relationships within care, and what are those promising social and relational approaches to care. So rather than define and measure quality of life or quality in general, our stream has really wanted to think with what's involved in assessing quality. So adopting a relational approach, we've considered quality within the context of a number of different things. So when we're looking at quality of life, we have to always be thinking about that in relation with quality of death, and that this is strongly influenced by quality of work and quality of care. So we've really taken a kind of critical sociological perspective on the issue of quality, and following the lead of Pat Armstrong, Dr. Pat Armstrong from York University, is one of the co-investigators on our stream. We've asked, how do the conditions of work impact what quality is and how it's experienced. So we've been interviewing and doing site visits and observations to try and understand how quality appears, and also wanting to consider how do some of the ways that we have already have of defining quality, how do they shape and play out in people's actual experiences. So I'm not sure if that's helpful, but really, thinking about assessing and understanding our current ways of defining and measuring quality, and using that to inform a kind of reflexive relational approach to enhance understanding and enhancing people's experiences within late life long-term care.
So it's Matthias. Maybe I can go next because it ties nicely into what Katie outlined, and just shows, for example, that the data that we are working with has huge gaps when it comes to depicting and measuring basically quality of life. The data that we're talking about, and that is the basis for the work in Stream 1 or in the monitoring care practices and burdens and symptoms theme, is administrative data collected from residents, and it's very clinically focused. So it measures things like daily excruciating pain, shortness of breath, depressive symptoms, things like these, which we think are very important factors influencing quality of life, but they're not reflecting quality of life. Since quality of life is the person's or the resident's own definition of and their own perception of how they're doing and how they are affected by these things. So the clinical data we're using reflects whether a resident is in pain or not, but it doesn't tell us what that means to the resident and what the overall situation looks like and to what extent their joy and their well-being are actually affected by that. However, we still think while the data is less than perfect to measure quality of life, that what it measures definitely has a huge influence and relevance for quality of life. And since it is collected routinely on a large basis, so you can really monitor the whole nursing home resident population over time and across different regions, leaving the data unutilized would be also an ethical issue. So we are trying to make the best use of it, but pointing out the limitations that the data has when it comes to important outcomes such as self-perceived quality of life, which will need to be measured using different tools. So there is some work in our team going on that's not related to SALTY directly, but that will feed and will be connected to the SALTY work we're doing on can we feasibly and reliably measure quality of life using a health-related quality of life tool that can be used with people with dementia in all stages that also has proxy assessments, and would be really interesting to see how people who do poorly on these quality of life on these quality of care indicators that we're routinely measuring, to what extent and how that influences certain parameters related to quality of life. So there is work to build on that, but we are not specifically measuring quality of life, but using administrative data in a ways that we hope can be used to improve quality of life later on.
Great.
Awesome. Marco, do you want me to go next from a policy perspective, or do you have a different question?
I would love to hear the policy perspective. Thanks.
Okay, and I think, the rotation we've got of sort of just what Katie and Matthias just said, we can build upon that in a policy perspective. So while Katie really talked about that relational aspect, from a policy point of view, our stream is looking at, so what kind of policy does support relationality? And Matthias's comments around symptoms, what kind of policy actually supports paying attention to those burdensome symptoms, and doing something about it. So in our policy stream, those are two really good examples of what we try to look at. Now, we looked at it from a very high level, so from a provincial point, not a regional point. We also looked at other things beyond relationality and physical comfort, using King's domains, We also wanted to know where policy spoke about spiritual well-being, and privacy and meaningful activities, individuality, some of these other kinds of aspects of quality of life that we know are important to people. So when we think about quality of life, and I'm curious about the comments you made, Marco, within the question around how do you measure this and how do you name it? I mean, I think that's the golden question, right? Because it's such a personal experience for each person. When you talk about quality of life, it's going to be different. So how do we actually support quality of life for a person in living in long-term care? At the same time, understand that we're talking about a lot of different people with a lot of different perspectives. So policy really tried to step back and look at how are we, in that very broad sense, supporting quality of life that really does speak to that individual. And it's not an easy thing to think about or do. And I think that's one of the, beyond the policy stream, all four streams, I think that's something that we're all wrestling with, and see as important, and is really is the driving force behind seniors adding life to years, which is in the SALTY title itself. So it's difficult to measure, but in the system we've got, until it changes, which is another thing that our SALTY project's about, is about propelling change. So it's kind of like the double Dutch rope, skipping rope. You know, you're dealing with one system on one hand and you're trying to propel it forward with the other and jumping at the same time. So the policy part of that really is looking at, so what kind of rules are supporting that kind of activity currently for people living in long-term care, but also with an eye to transformation moving ahead.
And this is Katie. Maybe just to build on what Dee has said, which is just absolutely correct. One of the things that we did as part of the mapping care relationship stream and mapping promising approaches is we interviewed what we're referring to as decision makers and leaders within the continuing care, long-term care sector. And we asked them, how are they defining policy or quality? What did quality mean for them? And a lot of the times when they spoke about quality, they really referenced their own lived experiences and their own close relations. And when they described, the kind of home that they would imagine as a quality nursing home or late life long-term care setting, they used examples from their own lives and their own local communities. And so I think that's really important to pay attention to as well. It just reinforces what Dee was talking about, insofar as, we bring our own experiences. It is a subjective experience, but I think it's something important that we need to pay attention to from a research perspective, because policy, those rules, they're structures that are there, but they're also being defined. And so if quality is so open, there may be some things that we need to think a bit about in terms of how are people interpreting those rules? How are they putting them into practice? And this may be more important now than ever, where we, at least it feels like we're on the cusp of the possibility for real structural change within the long-term care system. So what kinds of assumptions and experiences are people going to be bringing to those policy discussions and those roundtables? And how can we understand those assumptions so that we aren't just reproducing what already is?
Yeah, I think that's a great point, Katie, where like having that first person voice, especially people living in long-term care, they have the say of defining what quality of life means to them, because I think all of you were saying that it is a subjective thing. And that's what I found so interesting about the SALTY project, was how each stream kind of measures and looks at quality of life differently, whether it's like social and relational or more clinical, and then the policy, like how we can support quality of life under the rules and regulations the current long-term care system is in. So that, thank you all for those answers. I think the next question I'd like to ask is, so we talk about the difficulty in measuring and defining it. Why is quality of life in long-term care so important to study? Like why is it necessary to study, or maybe what needs to be in place to improve quality of life? Or from your perspectives, what would you change to improve quality of life for people living and working in long-term care?
So it's Matthias. I think I can build on the previous conversation in that regard. First of all, I don't think it's that difficult to measure, first, neither qualitatively nor quantitatively. What's difficult is to agree on which exact definition should be applied. And there were discussions among the SALTY team as well. But once you have agreed on a certain definition, there are validated tools and there is ways qualitatively to get at this perspective. And we're seeing that right now in our work. We're doing interviews with people in need of care, and somebody they define as a close person. That can be a family member, a friend, or it can also be a paid caregiver in that site. So the interesting thing really is that very often, and that gets to your question, why quality of life is so important, that very often what we measure in the tools that we're using quantitatively either is not at all mentioned by these people as being an important factor, or they mention things that may be measured in these tools, but that all the previous prioritization exercises with the decision makers and other persons were not considered that important. So the best example for that really is incontinence. That was excluded by many people from our list of possible outcomes to measure because people thought it's not really burdensome or you can't really do anything about it, things like these. Almost everybody in some capacity of the residents we interviewed mentioned urinary incontinence. And if they were not affected by it themselves, they mentioned other residents who are affected by that and who definitely think it's burdensome, such as a room mate or somebody they live together with in a room who was bedbound and was incontinent and was left in their soiled diapers by care staff for a very long time until somebody took care of them. This is definitely something that's super burdensome and that's preventable, and that's really affecting quality of life and dignity. Which is not reflected in the administrative quantitative data, like the importance of incontinence. So this is why quality of life is so important. It's really the perceived situation and how it affects you as a person, not how others think you might be affected. And quality of life is very, very important for another reason as well. People living in these institutions are at the end of their lives by definition. Like the average length of stay in Canadian nursing homes is around a year. In some provinces a bit more, in some provinces a bit less. But when they move into that nursing home, it's very likely their last station. Very few residents move out of a nursing home back into the community and die there. So they either die in that nursing homes within, on average, 12 months, or they are transferred to a hospital and then die there. And the conditions they have are chronic. You cannot cure them. You can, at best, make sure that the symptoms are managed so the burden is minimized and people can still do what they have enjoyed before, such as going into the garden, enjoying the nature, enjoying company of loved ones and all that. So the one thing we can do for these people, many of them who have dementia, is maximizing their quality of life, because we cannot cure the issues they're dealing with.
I think that's such a great example, Matthias, and it kind of speaks to some of the limitations that might come from conceptualizing nursing homes as, sort of an extension of hospitals, when really, these are the places where people live and where they need to have sort of more things that are going to improve their dignity and their well-being, rather than just necessarily their health conditions. And you mentioned dignity, and I know that's one of the, I'm pretty sure that's one of the Kane domains, which Dee mentioned. And I was wondering if Dee wanted to, if you wanted to describe those Kane domains for the listeners.
Sure. Well, I'll just go through the list. But before I do, just getting back to, again, building on Matthias' wonderful comments around quality and measurement, and your original question about why study it. And that this is exactly why. Because without studying and investigating in a rigorous way, the story gets untold. And so we're really just trying to tell the story in a way that promotes that quality of life, helps with transformation, and also works alongside the types of indicators that exist currently that Matthias was talking about. Really important. And then I'm at some point, maybe we'll get into the discussion, all of this is dependent on, are there enough staff? Are they supported to do what they do? And I'm assuming both Matthias and Katie will comment on that as well, but I'll just make a quick comment. Everything that we're talking about here in terms of quality also takes resources and support. So, but to get back to your question around the Kane domains, so there are 11. Autonomy and choice, pretty self-explanatory. These are, when Kane describes these domains, she does so from the perspective of residents. She doesn't do it from, and she does have if anybody's interested, just look up Kane, either the 2001 or 2003 paper, and she's got a lovely description, just like a little definition dictionary. So autonomy and choice, which is, do I as a resident have the choices that I want? Dignity from my perception. So what do I think is dignity, and is it being met? Food and enjoyment. So much discussion in long-term care around the food and quality of food, and just that sense of enjoyment or recreational activities. Functional competence isn't based on what you traditionally think, measured from a quote unquote activities of daily living, but really, do I have the ability to participate in the activities I want to participate in? Individuality, am I seen for who I am and not, room number 3B? Meaningful activities, which is self-explanatory. Physical comfort, privacy. Do I have a sense of privacy when I want to have that privacy? Relationships, super important. Safety, security, and order, meaning that very basic, do I feel safe? Do I feel like I've got, there's not unpredictability in my day in terms of sort of that sense of order, security and order. And spiritual well-being, which really is defined as from a person's perspective, what that means for them. Maybe religious in nature, maybe otherwise, but is that there? So those are the 11 domains.
Thank you.
This
Katie,
is Mary.
Oh. Go ahead. Go ahead, MJ.
Oh, I want to give Katie an opportunity to respond to the question too, but I also just wanted to flag, when Matthias was talking about, this being often the last place that people live and often don't live there very long. We also have another stream on our paper that, on our project on palliative approaches to care. And there's no trainee lead on that stream, but they play a very important role in this conversation around quality as well. And we've had a lot of discussion about, does palliative approaches to care, does that mean quality of life? Is that the same thing as enhancing quality of life, especially in late life? And we also have had a lot of kind of feedback from our advisory group members, which are, residents, staff, frontline staff, family members, people living with dementia. There's been a very lively discussion about whether we can talk about quality of life and not talk about palliative care, and vice versa. And so a lot of these we're really working through all of these different kind of subjective interpretations of what quality of life is and how it's best enhanced in long-term care through these various dimensions of the project. So that's really interesting. I guess it kind of ties into what Katie was saying about how subjective our interpretations are of these things, and why the SALTY project is perhaps unique in incorporating so many diverse perspectives on the question of quality of life.
Thanks, MJ. So maybe I'll take this opportunity to address your question, Marco, and I do agree with all of my colleagues with everything that they've said thus far. But I think something maybe that's novel or distinct that's come out of the work that we've done with mapping care relationships could be a somewhat different orientation to the question. So, what would we, I think your question again was, what would we change to improve quality of life and long-term care? And I think what we really need to ask is, for whom? So who are we imagining when we imagine changing something or improving something? Who is attached to quality? Using a social relational approach, we were constantly not reminded of, but in the midst of multiple perspectives. And so these were, different roles that people played, whether they're the frontline care workers, the administrators, the middle management, the residents, the different residents with different care needs and care situations, the family members, the volunteers, students is another group that came up, but also like which communities, which populations. And I think maybe one of the biggest challenges that we face right now with thinking about quality in relation to long-term care is that we really take a universalistic or universalizing approach, and it's quite abstract, and that can make things difficult. And I think even if we're just focusing on quality for the resident, it's still abstract. Like, which residents? We know that people have different situations, that there are inequities within the long-term care system and society more broadly that often go overlooked, and that can result in significant health disparities. So one group that I've been really interested in are people who are living with dementia and serious mental health challenges, and people that are from socially and geographically marginalized communities. We can also think about how this plays out within staff, within the care workers within a home, and how their experiences of work and their ability to deliver quality care are influenced by, maybe routine experiences of discrimination within the workplace that could be, implicit constant microaggressions, which are really can be challenging to address and to rectify. So I think we need to really think about the who in the question. And then, one other thing that might be important to improving quality of life and long-term care, or quality of work, or quality of death, and quality of care would be to destigmatize long-term care, but not to normalize. We hear so much lately about, the new normal, and I think many would agree with me that there's a lot of trepidation around that term. So long-term care is a distinct environment. It is not the hospital. It is not a psychiatric facility. It is not a prison. It is this institutionalized space nonetheless. Well, what is it? I think we need to destigmatize it, but not necessarily normalize it. This is a unique setting. So the only way that we can really understand its distinction is if we listen to the people who are most intimately engaged and involved in these environments.
Sorry, go ahead, MJ. I was going to say, just well said, Katie, as always.
Oh yeah, I was going to say that's so well put, Katie. I really appreciate that, thinking about destigmatizing but not normalizing. And I guess just leaping off of that tangentially, I'm wondering if maybe we can talk about, when you mention everyone's saying the new normal, I mean, the big thing that's happened in the last few months, and we've touched on it in our first episode too, is how the pandemic has shifted the way that we think about long-term care, and what is the relevance, I guess, of talking about quality of life in the various different ways that we do on SALTY, for helping us understand what's happening in long-term care right now. And I guess, where is quality of life in long-term care during a pandemic?
Well, that's a highly interesting topic, and a very sad one as well, I think, since everybody has heard of that. The pandemic has hit long-term care facilities especially hard, and most strongly among all developed nations in Canada. There is a couple of other countries who have not done well either, but no country has rates of deaths among the total population as high as Canada has in nursing homes. So there was, there were a couple of vulnerabilities in the system that have existed for quite a long time, but that they have been contained somehow until that crisis started. And then we had that outbreak, and with all the devastating impacts. So health authorities all of a sudden realized there is something they needed to do. And what they did is really they focused heavily on safety. So there were rigorous lockdowns of these facilities. Care aides could not work across different facilities anymore, while that is very often something they need to make a living, actually. But of course, it supported the spread quite drastically across facilities. Family members who are essential caregivers and essential contact persons, talking about quality of life, especially for people with cognitive impairment, but for everyone who lives in these sites, were not allowed to visit anymore. Many of the activities, which are usually already down to a bare minimum, basically, and which are not very individualized, but many of the activities like singing and group activities had to be canceled, couldn't be carried out anymore. As soon as there is an outbreak in such a facility, very often residents had to be confined to their rooms. They didn't see other residents anymore. It's not always the case, but very often facilities implemented measures as rigorous. So imagine you're a person with cognitive impairment, and all you see is a fully dressed and gowned up and masked caregiver coming into your care for your care, and only entering the room for essential care activities. What does that do to your orientation, to your quality of life, to your health and well-being? So the safety measures were critical to make sure people don't die anymore, but quality of life was put on the back burner very clearly, either intentionally or overlooked, but it was not well balanced. And due to family members not being able to visit anymore, we had other issues coming up, such as residents not having somebody to advocate for them anymore. So many important care tasks just didn't happen anymore because there was nobody there to remind care staff or to enforce things to happen. Residents were even more lonely than they were before, and all these things. So now I think the perspective again has shifted a little bit, and everybody realizes that we cannot just lock down these facilities, but we have to do it in a way that's human, that preserves and supports quality of life. But that's a difficult thing to do, because if you are short-staffed and you have minimal resources already, and if you're lacking PPE, personal protective equipment, all the gowns and masks that are needed to allow family members in, and if you don't have the resources to instruct family members how to properly behave and be safe and secure in these facilities, if there is nobody to help them with that, then there may be visitor policies right now, but facilities may not even have the resources and the capacity to implement them, to accompany residents and family members to go to the outside and stuff like that. So it is drastic, and everything that was a problem before has now been amplified to the power of 10, basically, due to the pandemic, and new problems have been implemented as well, such as I just outlined. How do we ensure the bare minimum of quality of life for people with, or for people living in these sites and their families, if we lock down the facilities so drastically? So yeah, I could go on talking about that. I do 2 studies on that right now, one on quality of life and one on family members' experiences with the lockdowns. But I'll stop and let others talk as well. So it's drastic.
All right. Well, maybe I'll weigh in on this as well. And it's interesting to talk about this because, of course, it's stepping out of my researcher hat. Of course, I'm one of the people who's got a parent in care with severe dementia and was actually and wound up with COVID due to an outbreak. So I can tell you that, you know, when I think about this from the policy perspective and the need to absolutely contain this virus and keep people safe, especially our vulnerable, frail elderly, you know, I can see why, how the importance of it, but as a family member for 2 months, knowing that you can't, just as Matthias described, it's exactly that. Can't talk to them. They're very, very confused. I can tell you that my parents survived the COVID, so that's good. But as we move ahead, it's not just, you know, considering second wave and how are we maintaining quality of life for people in a pandemic situation in long-term care. It's also the staff. Because both were really impacted. And as we move ahead, how are we, just as Katie said at the beginning, the conditions of work are the conditions of care. How are we supporting that so to enable quality of life, even in a pandemic situation? How are we supporting families through an extremely difficult time, not being able to comfort or reach out or understand, and knowing that your loved one is suffering greatly, even more than you know, some of the confusion that comes along with dementia and being placed in care comes along with. So we do have a lot of work to do. So it's not just how are we understanding how the pandemic changes things moving ahead. I'm also curious about how has this impacted the people now? Because it has. It's not like all of a sudden the doors are open and you're socializing again and things have returned to normal. They're not. There's a lot of fear around it. There's a lot of, still a lot of process involved with visiting and communicating. So, you know, this is exactly where research on quality of life for this population comes into play and is so incredibly important.
Thanks, Dee. And maybe something too. I mean, I think it's just such a crucial question. You know, where is quality of life during a pandemic? And some things that I get very concerned about, and things that we were also exploring as part of our work, mapping promising approaches, concern, you know, the use of restraints and psychiatric and environmental restraints with residents, particularly residents who may be living with some form of a cognitive impairment, but not exclusively, and how those restraints can be very much a part of the everyday life of a long-term care setting, even under non-pandemic conditions, right? So what does it look like when everything is amplified, as Matthias said? And so I really hope that there'll be some research that is monitoring the use of restraints and how things have changed over this period with COVID and moving forward into the future. And something else that's really important to pay attention to would be, what about what's treated as essential? So family, for example, may not have been recognized in many ways as essential care partners and essential caregivers. And their labor wasn't valorized in the way that it should be. It's really critical to the whole operation of a home or a site. But I think we need to think about what is treated as essential then. Something that we noticed when we were doing our observational research was that the community programming within many long-term care homes, that was really essential to quality. People looked forward to paint night or wine night. And we saw some excellent examples of arts programming that really supported meaningful engagement, not only of the individual resident in an activity, but of people who live in this place with one another and with the care workers that were there, and often the family were also present as well as other members from the community. So what will be the impact on the relationship between nursing homes and communities from the pandemic? And I think just to end on this thought, it might be really important to try and identify some promising approaches that are happening with respect to quality and long-term care. Right now, as part of the pandemic, there may be pockets where there's really exciting connections that are being maintained and sustained and even that are growing through people strategizing and negotiating these new conditions. So perhaps we can kind of be paying attention to not only the severity of the situation and the potential for harm, but also what are some really promising examples where people are doing things differently, and how can we learn from that?
Yeah, thank you, Katie. I think that's a great point. Trying to find some optimism in all this and looking at the promising approaches. I see we're coming kind of close to the end of the time here. So does anyone have anything else they want to add?
I'll maybe just add, as we're looking at promising approaches, because I agree that's a great thing to focus on. How are we planning for future so that the long-term care, as we know it now, doesn't exist in the future? In terms of, that institutionalism, how are we supporting promising new initiatives that really are about aging in place, community care, and really reinventing this notion of what it is to be at the end of because each of us will get there, at the end of our own lives, and what's going to be important to us, and how does that look in terms of our end-of-life journey and our end-of-life experience. So I think we have the intelligence, the will, and the passion to really focus on that as well as we move ahead.
Yeah, I want to add to that. I also am very, very supportive of the positive lens and showing what works well already and what can be done. And I think going even beyond showing what is possible and showing the promising approaches, it looks to me like we as especially researchers will have to take a different approach than we may be used to and that we're trained to. And that really focuses on also trying to influence public attitudes and just transport what we're just talking about here. And the podcast is an excellent start for that, into the public. And for me specifically, and I know for many of my colleagues as well, that's stepping outside your comfort zone, because you cannot just argue with evidence anymore and stay within your parameters that you're trained to. It's really dealing with the public, but without public support, who votes for the right government and the right approaches, and who are willing to put more money, more resources in the system, and to help transform that system by supporting certain approaches and not supporting others, or even being willing to deal with that stuff and not neglect it anymore. we need to get in contact with the general public and advertise these approaches and these attitudes way more than we have been doing so far. And as I said, for me and for many of my colleagues, it's really stepping outside of a comfort zone and probably even needing support, better doing that and more systematically doing that, I think.
Thank you. I'm hoping we have more conversations about these kind of promising approaches and the kind of strategizing that people are doing in relation to long-term care during the pandemic in our subsequent episodes. We're planning on talking about family, staff, palliative approaches, and we're interviewing more of the trainees and some of the advisory group members for their perspectives as well. So I think there'll be some interesting conversations coming out of this, and hopefully, this podcast can be a small part of that, building that kind of public conversation about the changes that we can make.
Yeah, and just to wrap up, I want to say thank you so much to all of you for having this conversation. I really enjoyed it. You each bring such unique perspectives, and really I feel like we've had a well-rounded critical discussion on what quality of life is in the context of long-term care.
Thank you, everyone.
Thank you.
Thank you.
Thanks. Bye-bye.
Thanks for joining us for this episode of Let's Talk Care. This show is sponsored and produced by SALTY, Seniors Adding Life to Years, a research project aimed at improving quality of life at the end of life in long-term care. Make sure to visit our website at saltyltc.ca for more information about the SALTY project, and follow us on Twitter at @salty_LTC so you don't miss our next show.